Welcome to Oncology Today, new data sets in FLT3 and IDH1 and 2-Mutant Acute Myeloid Leukemia. This is medical oncologist Dr. Neil Love. For this program, I met with Dr. Jorge Cortes from the Georgia Cancer Center at Augusta University in Augusta, Georgia. Conflict of interest statements can be found in the program notes, and the use of agents and treatments that are not approved may be discussed in this program. So check out the package insert information for more. To begin, I asked Dr. Cortes to briefly review FLT3, IDH, and other common genetic alterations that may be detected in patients with newly diagnosed AML.
That's very important, especially now that we're starting to get these targeted agents. And FLT3 is probably the most common mutation. We see it in grossly about a third of the patients at the time of diagnosis. So that is important. We see it more in the de novo patients than in the secondary leukemias. One subset of patients that interestingly is almost always positive is APL, but of course we don't use FLT3 inhibitors in APL. The next most common mutation is NPM1, and that is important because there is an emerging group of drugs that are called menin inhibitors. One of them has already been approved, but it's not approved for NPM1. It's approved for KMT2A rearrangement. So that's the rearrangements that include the long arm of chromosome 11, those 11 Q23 translocations. But they've also shown to have benefit in NPM1. I think the approval in NPM1 context is going to come very soon. There's a number of drugs that are being developed in that rate. So that also is about 30% of patients. The IDH mutations, each one of them, IDH1 and IDH2, they happen in about 8 to 12% of the patients, 15%. So each one of them individually, that in that range. And then there's others where we don't have a specific targets. DNMT3 is common, RUNX1 is common, TET2 are common, ASXL1 are, all of those are relatively common. And they're also part of those changes that we see as part of these clonal hematopoiesis of undeterminate prognosis that chip that we're still trying to figure out what it means. But those are some of the most common. Of course, there's many other mutations, and many times when we send these NGS sequencings, we get many others that have less of a clear prognostic implication.
So you mentioned secondary AML, which I assume gets higher incidence as people get older. Again, any difference in molecular profile in those patients? And also, what do we know about CPX plus targeted therapy?
Yeah, very important. So yes, the secondary leukemias tend to have a couple of things that stand out. More of the MDS-related mutations, and so we see RUNX1 there more. We see these epigenetic modifiers. So those tend to be more common in patients with secondary leukemias, and also P53. P53 is more common in the secondary leukemias, and which is unfortunate because those patients have a worse prognosis. And as I showed in some of the slides, none of these agents have really touched P53. CPX, as you mentioned, is a drug that is approved specifically for secondary leukemias, whether with myelodysplastic-related changes or with or secondary from prior therapy, and it has a survival benefit. There have been a number of studies looking at combinations with these targeted agents. There's been reports, for example, combining it with FLT3 inhibitors, showing very good results. It's still unclear whether they are better than if you would use just standard 3+7. But that is a very active area of research, and my guess is that at least for some subsets of patients, there will be a benefit of using CPX with a targeted agent versus standard chemotherapy plus the targeted agent.
So for practical purposes, can you or have you combined CPX with either a FLT3 inhibitor or IDH inhibitor?
I have. It's not approved, so that's a limitation, but I have used them. CPX is a little bit more myelosuppressive already, but I haven't seen that the addition of when I've used a FLT3 inhibitor, for example, that it really extends the myelosuppression much more.
All right, let's drill down a little bit more on the first part of your talk on FLT3, and maybe you could just comment a little bit about the clinical presentation of patients with FLT3 disease. Are you able to guess that a patient has FLT3, and what's a typical presentation?
One thing that stands out is that these patients tend to be very proliferative. So meaning they come up with a very high white cell count. So that kind of always makes you think that it's possible, and considering that it's a relatively common mutation, that's important. Now, we usually use NGSs, but because we have a targeted agent and because they're very proliferative, many laboratories can do just a FLT3 mutation analysis, which can give you those results quicker, because the NGS can take 2 weeks, 3 weeks, or something like that.
So let's talk a little bit more about clinical data with the FLT3 inhibitors. And while you were talking, I went back and looked to see that it was 2017 that we saw the RATIFY trial published anyhow. So it's been a while. And it's amazing, because you can imagine how many times we've talked about this concept in CME programs since that time. And for some reason today, watching you go through that, the evolution with the quantum study, something hit me that I wonder if other people, maybe I'm the last person to realize this, but I was struck by the impact. The hazard rate was really significant. Actually, I didn't see a hazard rate on the RATIFY study. I don't know if there was one, but the difference in survival was, I think, 75% versus 25%. And I really wonder whether people am I correct in saying that this is survival? For some reason, I never realized. Am I correct in saying it has a huge impact?
It does have a huge impact, and probably what happened is that the long history of the FLT3 inhibitors, because we've been after these for a long time, and how long it took that RATIFY study to read out. So it kind of made it sound like, gee, finally, and it there was probably a little bit of fatigue and all of that. But you're absolutely right. This is transformational in terms of the impact that it has in the diseases. Now, I doesn't mean we're done with this disease, because there's still room for improvement, but the change that it provides, the impact that it has, really makes it clear that that's the way to go. If you have a patient with this disease, you really have to give them, and midostaurin and quizartinib are both approved. I think quizartinib is better in that context, but midostaurin works.
Any thoughts about you also, as long as you bring up that topic, one of the things you comment on was the ECOG study that actually compared the two, which I thought was kind of surprising. Maybe, you showed that at least at this point, the MRD rate is higher with midostaurin. I'm curious, I don't know whether, midostaurin also, people don't like the smell or whatever, they don't like it. But, and I also thought it was, quote, a dirty TKI, and yet, it seems like it maybe is kind of comparable to, I guess, quizartinib anyhow.
Yeah. No, it is a good drug. You're right. I think it has a little bit more side effects, more GI toxicity and the smell and things like that. It's that study. It is a surprising finding, and it's interesting. And I don't know if it's just gilteritinib or it would apply to quizartinib. Gilteritinib has been very surprising, because the other study that I briefly mentioned, I didn't show a slide, but I mentioned it briefly, that azacitidine alone or with gilteritinib, that was a negative study that I was, I would have bet that it was going to be positive, and yet it was negative. And here's another one where, You don't now. I want to see the longer follow-up, see if survival, relapse-free survival. I don't know, but seeing those early results, I suspect no, it's going to be negative. And well, maybe midostaurin. When you look in vitro, the other drugs are more potent, but maybe you just need to hit a certain level of inhibition, and the extra is not of any additional clinical benefit.
Really interesting. So here's another surprise that, again, you probably AML people talk about this all the time, but just, we're cruising between all these different cancers, and just seeing your presentation, a thought came to my mind, and I looked it up also, that aza-ven was approved, accelerated approval 2018, so just 1 year after RATIFY. Am I correct in saying in 2025 we don't have a randomized trial of aza-ven plus or minus FLT3 inhibitor up front?
Right. There's no randomized. There's all these studies are all single arm, and many of them single institution.
I mean, I find it surprising. I feel like there should be enough patients out there. Why are there trials ongoing?
Not randomized. No, not that I know. And I think that because there's so many options, people think that there's not going to be able, but because they're all split into all these different phase 2 single arm studies. But yeah, if you put them together, there's plenty. I mean, I think that the main reason why people are not doing it is because, again, the memory of RATIFY and how long it took to read out. But I think that you can change that by changing the endpoint. The endpoint initially was what was affecting that the readout for RATIFY.
You see a lot of randomized studies in oncology nowadays of, pretty small subsets, mutational subsets and non-small cell, and, a lot of things that are not very T-cell lymphoma, somehow we get these studies done. Yeah. So, well, that just sort of kind of shifts into a pretty practical question, which is, what do you do with a patient with a FLT3 mutation who's not eligible for transplant? You're going to give aza-ven to. Are you going to include FLT3 inhibitor in that patient's therapy?
I am. I do it. I wish I had a more convincing demonstration that that's better than aza-ven alone. But I think that in principle, I believe that there is a benefit. I mean, the single arm studies, the response rate is impressive. The duration of response is pretty good. So that's what I do. Yeah.
Which FLT3 inhibitor, and any issues with combining it with aza-ven?
I tend to favor quizartinib. I like the safety profile. Granted, it has that QTc prolongation, black box, but really clinically, it hasn't translated into any other problems. And other than that, it's a very clean drug. And because it's worked in the salvage setting and in the frontline setting, I like that. So, and it doesn't add much, but you do need to cut the number of days of the quizartinib. So I don't go the 28 days, usually 14 days, and then you stop if the bone marrow shows no blasts.
What about aza-ven in patients with TKD?
Well, in that context, you can use just aza-ven, or you could use midostaurin or quizartinib, because those two drugs work in TKD. So that's probably what I would do.
So the other, I found really shocking data that you talked about. And again, I don't know, I see it from ASH, but I don't know if it was out there before then, like this Kiwi study.
Yeah.
Non-FLT3 mutated patients, unbelievable. I mean, good hazard rates, right? So like what, now there's a phase, first of all, what's going on? Maybe you can talk a little bit about this FLT3-like profile. And, now there's a phase 3, I don't know how long it's going to take for this phase 3 quantum wild type study to get reported. I imagine it's going to be a while, but any thoughts about this and where it's heading?
Yeah, very, very interesting data, and could be, very impactful, probably more than the FLT3 mutated patients, because 2/3 don't have a mutation. So it would apply to more patients. And again, we had reported the single agent data, 30% response rate in refractory relapse single agent quizartinib was impressive. Of course, it was natural to continue the development of the drug in the FLT3 mutated, but that information was there. So this is really very important. I think that this FLT3-like gene profile, it's similar to what we see with the Philadelphia-like ALL. It's the same concept that you don't have the Philadelphia chromosome, but you have all these other gene expression that is similar to. The difference here is that in that context, we really haven't found a drug that works for those patients. We've tried tyrosine kinase inhibitors and JAK2 inhibitors, but nothing really stands out. Here, the FLT3 inhibitor seems to work very well. Obviously, you would like to take that, number one, confirm it, and Quantum Wild will confirm that, or will tell us if it is confirmed. But the other thing is that it'll be ideal to then simplify that into a test that's more clinically applicable, because these gene profiles are good research tools, but clinically they're not as practical. So it'll be good to develop something that your laboratory can give you the results quickly.
When you were talking about that, the thing that flashed into my mind, I don't know how much exposure you get at your place to ovarian cancer, but there with PARP inhibitors, you have, BRCA mutations that these patients respond to. But they also have this assay called an HRD assay or LOH assay, which is kind of BRCA-like. And these people seem to respond similarly. Kind of reminds me what you're saying, sort of. I guess it's very similar.
Yeah, exactly. That's a perfect comparison.
Also, it's interesting in terms of, again, now you're really getting down to small numbers with this Kiwi study, which other mutations. And one thing I was curious about, and I was just in general curious what your thoughts are about patients with both FLT3 and IDH. I don't know how often it occurs, but I think you said that they didn't seem to benefit, but at least in terms of survival. But I was wondering, do you think a lot of those patients got IDH inhibitors later on, and maybe that affected the survival analysis?
I think so. I think that that's part of it for survival, because there's a good IDH treatment. They can relapse, but you can salvage them very well. So I think that that's a good part of it. Yeah.
How often do you see patients with both IDH as well as FLT3? And in your mind, which one takes precedent? Do you look at their clinical presentation, in terms of whether they're proliferative or not, or how do you decide what to do there? You get both?
It's not very. Yeah, it's not a very common combination. FLT3 is very common, but IDH is not. So, you probably 4 or 5% of your patients will have something like that. If I can, I would keep both, but that's not. There's no clinical data, there's no trials or anything that show that. I favor the FLT3 because that has a poor prognosis. IDH is a good target, but it doesn't really impact your prognosis as much. So I favor the FLT3 inhibitor versus the IDH inhibitor.
So before we get into more about IDH, and particularly this new IDH1 inhibitor that's now become available, just a couple more words in terms of FLT3. You kind of alluded to the, quote, favorable toxicity profile of quizartinib. And I'm curious, in your mind, how you think through first-line therapy of patients who are going to get chemotherapy and transplant in the FLT3-ITD patient, how you decide between midostaurin and quizartinib, and in general, how would you compare the tolerability profiles and efficacy?
Gee, I mean, it's a difficult question because we don't really have the direct comparison, and overall the curves look both similar from RATIFY and from Quantum First. I do like the safety profile of quizartinib, very well tolerated, and the QTC. We know we need to be careful with the potassiums and magnesiums, but we use Sofran and we use quinolones, and we use all these drugs that prolong that. So as long as you're monitoring and being careful, that it's been very rare that's been a report of a significant arrhythmia. So I like that toxicity profile, and at least in principle, I think it provides a deeper response, more MRD negative patients, and I think that that's valuable going into transplant, and of course, even more if you're not able to do a transplant.
So let's talk a little bit about IDH mutant disease. Can you talk a little bit about the 3 available IDH inhibitors and how they differ?
Well, the enasidenib is the only IDH2 inhibitor. That was the first IDH overall that was approved, and it's very effective. So that's the key differentiating factor for that one. Ivosidenib and olutasidenib, they're both IDH1 inhibitors. There hasn't been comparisons head-to-head. Both are good. When you look at the data, their overall response rate looks similar, but there is more of CRs with olutasidenib than with ivosidenib, and the duration of response is much longer with olutasidenib. Again, in different studies. So whether there's other reasons that is not the drug that explain those differences needs to be determined. In vitro, there are differences of the drugs. Olutasidenib has a higher binding affinity to the IDH. It binds in 2 sites instead of 1. It is more specific. Ivosidenib also inhibits unmutated IDH. So there are some differences there. Whether that explains the difference, if there is one, we don't know yet. But there are some differences both at the biochemical level and in terms of the results of these studies. Now, the approvals are also different because ivosidenib is approved for frontline and also in combination with azacitidine, which olutasidenib is only approved for refractory relapse and only as a single agent.
So can you talk a little bit about the issue of differentiation syndrome with these agents? Do you observe it? Any recommendations in terms of detection, prevention, and management?
Absolutely, and that is common to all 3 drugs. This is a feature of both the IDH2 and the IDH1 inhibitors, and it is very important to keep an eye on that. When I remember when we started treating the first patients with ivosidenib, enasidenib, which was the first drug that we started in phase 1 studies, I am sure that some patients that we took off study early as progressive disease were having differentiation syndrome, which at the time we didn't realize that was a feature of these drugs. Of course, now we know that, but it is important to recognize that the differentiation syndrome, although sometimes it comes with an elevation of white cell count and even a transient elevation of the blasts, many times it presents without a change in the white cell count, but with other manifestations, fluid retention, decreased oxygenation, some renal dysfunction, very similar for those who have managed patients with APL, with promyelocytic leukemia, to what we see with ATRA. It's the same differentiation process. So, those patients many times have those symptoms without having a change in the white cell count. Very important to recognize it early, treat it aggressively. Corticosteroids tend to help the patients if the symptoms are mild. If the white cell count is going up, hydrea to try to control that white cell count. Many times it helps to stop the therapy with the IDH inhibitor, let the differentiation resolve, and then restart the therapy. But that's the key. If it's properly recognized early and treated, it can be managed well. If it's not properly recognized and treated, it can be lethal.
So I often find myself looking at complicated diagrams of biologic pathways and not understanding too much. Sometimes it's easier for me to hear somebody explain it like I'm on rounds. So could you take a shot at explaining your vision about how, sort of biologically, how IDH inhibitors work, and then what the mechanism is of differentiation syndrome in your mind?
Yeah. So the way this works is that the IDH, the mutated IDH, if you remember, our biochemistry classes when we looked at this at the Krebs cycle, that's how we called it in those days. Um, the alpha ketoglutarate is part of that respiratory cycle. And when IDH2 is mutated, it converts the alpha ketoglutarate into 2-hydroxyglutarate. And 2-hydroxyglutarate has a pro-leukemic effect. It's an epigenetic phenomenon that works similar to the DNMT3 mutations and so on. So that it creates it blocks the differentiation of the cells through epigenetic modulation. Um, Actually, patients with IDH mutations, they have a high increase in 2-HG hydroxyglutarate levels, which you don't see in a normal individual. When you use an IDH inhibitor, those levels come down. So it's kind of like a surrogate marker. We don't use it in the clinic, but in the research, it's a way to show that the drug is working. And that's why. So because this inhibits the differentiation, when you block that, now you induce the differentiation of the cells again. So this is not a cytotoxic drug; it's a differentiating drug. And as part of that differentiation, there's a release of certain cytokines that produce those symptoms of fluid retention and renal dysfunction and all of that are strong enough in some patients to cause clinical manifestations. It probably happens in everybody, just that in many instances it's subclinical, but in some instances it's big enough to cause clinical symptoms.
How do you explain why, when you use an IDH inhibitor in a solid tumor like biliary tract cancer, you don't see differentiation syndrome?
I don't know if the mechanism in a hematopoietic cell, which is circulating and more freely, triggering into the blood, it causes that. It's immediately distributed throughout the body, whereas in a
Right.
solid tumor, it may be a more confined environment that controls that locally. I'm guessing. I don't know for sure, but that may have something to do with that.
So I'm curious, when you use these agents, and maybe you can compare them indirectly in the relapse setting, what do you see? Do you see useful responses for prolonged periods? What's a typical response that you see in patients?
Yeah, as a single agent, you do see useful responses. The response rate is in refractory relapse in the range of 35 to 40%. And the median duration with ivosidenib is a little bit short of 10 months. With olutasidenib, it's been over 25 months. So it's more than
Wow.
double with olutasidenib. Again, there may be just different populations, but that's what the studies have shown. So now, what that means is in both instances, you eventually lose a response later with olutasidenib, but still you lose a response.
So here's another surprising thing that I think your talk reinforced, which is, I'm going to say the same question I had about FLT3, which is, what do we know about the most common therapy being given to AML in general, probably, and obviously in older patients, aza-ven plus or minus IDH?
Well, that's a particularly interesting combination because aza-ven has, in
Right,
contrast to what happens with FLT3, where it doesn't work as well, aza-ven is very good treatment for IDH mutated patients. So
right.
So it'll be interesting to see, and here again, we need a randomized study because the data that I showed with aza-ven plus ivo or plus oluta looks impressive, but is it better than aza-ven, which is already pretty good? So that'll be interesting. And my guess is that for that, it may be better, but the difference is probably going to be smaller, and it may take a larger population to demonstrate that it's statistically significant, just because you're starting with a higher standard with the aza-ven alone.
And actually, I mean, the trial would have to be really aza-ven plus IDH up front, or aza-ven alone and IDH on relapse, and then what would you get the best survival with? You know, maybe it's better to do it sequentially. And as you say, it's going to be hard to improve. I mean, it's really amazing. Do you have any idea why aza-ven works so well in IDH patients?
Well, they seem to be very dependent on BCL2, so I think that's part of the reason. But going back to your comment, my bias is that the sequence is at least as good than the concomitant use. So I kind of favor that.
All right, let's talk about, you have a couple of cases here. Let's hear about your 68-year-old lady.
Yeah, so this is a 60-year-old lady, and she has a high white cell count, 53%, comes presents like that, and that's why it's referred to us with a high blast count, low hemoglobin, low platelets. This patient is in pretty good overall condition. She's been healthy, not major comorbidities. And we do the bone marrow, and she sure enough has an AML, and she has a FLT3-ITD and as well as an NPM1 mutation. This is what in the European Leukemia Net would be considered an intermediate prognosis classification. So I put here the options that you could consider for these patients. Aza-ven, just because she's 68, and sometimes we tend to think about over 60, 65 to use that combination. Gilteritinib, trying to use less intensive, but with a FLT3 inhibitor, or a 3+7 based treatment. And you could do it alone. You could do it with midostaurin. You could do it with quizartinib. You can do it with gilteritinib. So that was a discussion, the conversation I had with the team, with the fellows and the nurses and so on. These are all the options that we could consider. And I didn't put the triple combination aza-ven gilt, which could be also considered. So that's kind of your mental algorithm that you have to go to, and there are many possible options. What I did for this patient is the 3+7 with quizartinib. Remember that study, the upper age of limit was 75. So clearly, on a patient, we shouldn't base it on age. It's fitness, it's the condition of the patient, and as we talked earlier, the hazard ratio is impressive. So you want to go with what gives this patient the best chance of response, of long-term survival, and possibly even cure. This patient can be transplanted. So I want to give her the best treatment option that will give me the best chances of a good response, and then probably follow that with a transplant, which is what we did with this patient. We eventually did take her to transplant. But now, to me, the other option that would be considered is midostaurin. I mentioned earlier, I'm a little bit biased towards quizartinib. I think it gives better results. But if I didn't have quizartinib available, if in some institutions it may not be in formulary, whatever, midostaurin is a good option for these patients as well, with 3+7, a RATIFY type of therapy.
So what's the current status of the patient?
Well, the patient is fine now, MRD negative after transplant. She's probably 4 or 5 months after transplant, something like that. And she She ended up getting one additional cycle of consolidation after induction because looking for donors and getting her ready and so on, and then went to transplant. So she's doing well. Has had a little bit of GVHD, but nothing really major. So I mean, she has a pretty good chance of being cured. It's a little early to tell, but I think she has a very good chance.
So I'm curious, in situations like this, do you just say, hey, this is what I'm recommending to you, or do you bring up any other options that might you want to consider? If you have a patient who says, wow, I've heard a lot of bad things about chemotherapy, do I really need to take it? What happens if I got, AZA, Ven, and a FLT3 inhibitor? How would you compare long-term benefit? Like, what would you say to a patient like that? And was this lady very involved, or she's more like, tell me what to do?
She was involved, and I do go through. I said that I discussed all these options with the team, but I also discussed them with the patients. I think it is a very important point that you bring up. Yeah, we need to give the patients the plan, because we may have a certain bias, but some patients just don't want to get the intensive chemotherapy. And I mean, our job is to explain it to them and give them the reasons for preferring one versus the other. Um, but it's ultimately their choice. It has to be an informed choice, but it's their choice. Yeah.
So my question is, a lot of people say age is just a number, but I'm sure if you had a patient with the same clinical situation who was 90, you probably wouldn't have offered the same options. I'm curious what the age is at which, even if a patient's, in good shape, no major comorbidities, where just age alone will get you to pull back from the chemo transplant route.
Well, I don't know that I have a strict number, but I think as you start getting closer to the 80s, probably it starts getting a lot more of an age factor. You're right. I mean, a 90-year-old, I mean, it can be in perfect shape, but it's hard to give chemotherapy to somebody in their 90s. So yeah, I would say that getting close to the 80s, you probably stop thinking about intensive chemotherapy. We also shouldn't forget that aza-ven is very myelosuppressive. So it's good in terms of no extramedullary toxicity, but we have to be careful. If it's somebody who doesn't have good access to transfusions and a place where they can take care of an infection and things like that, then it becomes intensive chemotherapy because of the risk of infections and things like that.
All right, let's go to the next case.
This is a 78-year-old patient, again diagnosed with AML, and then you have you do an NGS and you have an IDH1 mutation. This patient, in addition, this one does have comorbidities, has a history of a heart attack, has some diabetes that is okay controlled, not great. Has some renal dysfunction that more age related probably. So a little bit more of a borderline kind of patient in terms of comorbidities. So the options then are aza-ven, aza-ivo, aza-oluta, or single agent ivo, oluta, or enasidenib. So here we're talking about for one, single agent versus combination, and then what combination. Uh, the combination of aza-ven or a combination of aza plus an IDH inhibitor. So those are important considerations. Now, granted, Oluta with AZA is not approved in any instance. Oluta is not approved for frontline. So if you go just by approval, you would eliminate those two Oluta options. And of course, enasidenib, I just put it there as a trick because that's an IDH2 inhibitor. So you wouldn't consider that. But aza-ven, aza-ivo, and ivo alone are approved and appropriate for a patient like this. Now, here what I did for this patient is azaven, and the reason why this is being used very frequently in this context is more of a practical issue, and that is once you get a patient like this diagnosed and ready to go with chemotherapy, you can do that regardless of whatever the NGS shows, which is going to take 2 to 3 weeks to get the results. And although we have shown, there's many studies that have shown that the delays in therapy waiting for the NGS doesn't adversely affect the outcome, that is one thing. The other thing is, I have a patient that has AML and they want to get treated. They're ready, and just tell them I'm waiting because I'm waiting for a test, and um, it's sometimes uncomfortable. And we know that azaven is good treatment for those patients anyway. So even if you started with azaven, would I change to an ivo combination? No, I wouldn't, unless there's no response, of course. But otherwise, I know I'm giving them good treatment. So the practical element of having a treatment that I can start right away, and sure, I want to get an NGS. Everybody should get an NGS. But I have it there for what's next rather than having to wait to initiate my treatment and have a patient anxious and worried for 2 or 3 weeks without doing anything. So that's what we did with this patient, azaven, and now could you do aza-ivo? Yes, of course. If you get those results, if you want to wait, that would be my next choice.
So, going back to our previous discussion where you like the idea of azaven in these patients because they respond so well, and then coming in later on progression with an IDH. The other thing is just from a practical point of view in terms of approvals, if you go azaven up front, then on relapse, you could use oluta, which from seems like indirectly maybe it'd be more effective, and maybe in the long run, the patient would be better off with that sequence. Any thoughts?
Yeah, absolutely. That's exactly what my thinking is. And by the way, there has been historically not much data of IDH after a VENT study because the ivosidenib and enasidenib they were studied earlier when azaven was not as established. We just published a little bit of data of olutasidenib after VEN failure. And the response rate seems to be the same as without prior VEN. So, which further supports what you just said. And yeah, that's my algorithm. azaven, if they relapse, follow with olutasidenib, which is my preference. Although again, ivosidenib is a good option.
This concludes our program. Special thanks to Dr. Cortes, and thank you for listening. This is Dr. Neil Love for Oncology Today.